My name is Marc Léon. I come from Marseille, France, and it's a pleasure to chair this session with Thierry Calandra from Lausanne. The session is a fresh look at corticosteroids, and my pleasure to introduce the first speaker, Gruit Vandenberg from Leuven. And the talk is Rethinking Critical Illness-Related Corticosteroid Insufficiency.
I'm going to remove the mask if it's okay for you. Thank you for the invitation to speak about critical illness-related corticosteroid insufficiency, or what people think this could be. I have no conflicts of interest to disclose because all the work I will be presenting is financed through governmental research grants from Belgium and Europe. So let's go back to the starting point. So it is well known that increased cortisol availability in the circulation is essential in the fight or flight response. And this is, at least according to textbooks, brought about by an activation, a central activation of the hypothalamus, releasing CRH to activate the pituitary. That makes ACTH in the circulation. This activates the adrenal cortex to synthesize and release cortisol, which then exerts negative feedback inhibition at both the pituitary and the hypothalamic level. And given that critical illness is, of course, a very severe physical stress condition, it is no less so in this situation. And the function of the increased cortisol, as you know, is multiple: to control inflammation, to provide essential metabolic substrates, to retain fluid in the circulation, and to increase cardiac output and blood pressure. The question, of course, is this a system that is always normally functioning, or can this system fail? And of course, the answer to this simple question is yes. We know this from the endocrine textbooks, and let's refer to this endocrine definition as absolute adrenal failure, which can have three origins: two central ones, the tertiary adrenal failure when the cause is in the hypothalamus, or secondary adrenal failure when it's in the pituitary, or primary adrenal failure when the cause is within the adrenal cortex. All three conditions, of course, have low plasma cortisol levels, but the two central ones have low ACTH, whereas the peripheral one has high ACTH, and that allows the differential diagnosis. This is the endocrine definition. This can lead to critical illness and then be the reason for ICU admission, but this is not what we're talking about, basically. What we are talking about in our ICU setting is, can this vital system fail partially, which is a concept that was launched by Gilali Anane many years ago, which he considered to be an adrenal cortex that is maximally stimulated, but this is not enough for survival. And he based this concept on an association study where he found that when the synactin response, or the incremental cortisol response to a synactin injection, is below 9, that this was associated with the worst outcome. And this irrespective of whether the cortisol is high, normal, or low. So this additional stimulation of the adrenal cortex would be suppressed according to his interpretation, and that was then labeled a relative adrenal failure, not enough for survival. In this context, what you expect, of course, is a very high plasma ACTH, a maximally activated HPA axis, but this ACTH part of the story was not really taken into account at that time. Now, for the last decade, or a bit more even, we have been trying to look at all these data from a different viewpoint. Is this really a failure of the HPA axis? What you see is not always what you get, because is this a cat on a toilet or a guitar? Or is this a guy with nice dark hair, or a bald guy with a cat on his head? So the data can be interpreted differently. So we started to do a series of studies to better understand the pathophysiology of the HPA axis response in critical illness. First of all, the most important finding is that ACTH, this is data from a mixed ICU population. Cortisol is high, this is well known, but ACTH is actually low. Low from the start throughout this first week in all these patients. So this is referred to as an ACTH cortisol dissociation. Then we did some tracer studies, tracer technology methods to measure how much cortisol is actually being produced in ICU patients. And much to our surprise, this is hardly increased. In patients without SIRS, it is perfectly normal, and in patients with SIRS, it is like double the normal amount, but not 6 to 10-fold higher, as people have always been referring to this based on assumptions. And in another study where we measured nocturnal secretion, pulsatile secretion, we found that the pulsatile ACTH secretion and the pulsatile cortisol secretion in ICU patients is lower than in healthy subjects, lower, and yet they have high cortisol levels. Instead, we found that in all patients, very robustly, the cortisol clearance, the plasma clearance, is suppressed. So they don't break down the cortisol. They don't produce a lot more, but they don't break it down. And that explains why if you inject a known amount of cortisol, like 100 milligram of hydrocortisone in ICU patients, the decay curve is completely different than that in healthy subjects. In healthy subjects, you've got a nice bi-exponential decay, and in ICU patients, it just doesn't clear at all over the 5 hours that we measured it. So it's not being cleared. A second aspect of the increased cortisol availability is that immediately upon the stress response, it is no longer bound in the circulation because the binding proteins that normally keep the cortisol in circulation are immediately suppressed. We've done some mechanistical studies to say that that actually is a response to the first increased cortisol level and action in the liver. So CBG goes down and the binding affinity goes down, so the free fraction is high. So to summarize, unlike or in contrast to what people have been thinking before, increased cortisol availability is present, but this is due to reduced binding proteins and binding affinity and suppressed breakdown, but not due to an increased ACTH-stimulated production. Most of these studies were done in the first week, 10 days, let's say. But we were interested to see what happens later. What in the chronic phase, if ACTH is low, does this continue to be low? What happens at recovery? So we did a study in which these data were from the first week, and then we did a study where we looked beyond that first week. We actually focused on the right panel here, patients who would be in the ICU or stay in the ICU for 4 weeks or more. But we also kept the patients in the study who were in the ICU for 3 to 4 weeks, 2 to 3 weeks, and 1 to 2 weeks. So all these patients stayed longer than 1 week. We measured the plasma hormonal levels, and we did repeated synactin tests. Remember, that was the first definition of the adrenal failure. And what you can see here is that the low ACTH levels that were there from the start are still low, increasing a little bit, but never become high. And very strikingly, 1 week after the patients were discharged from the ICU, then they had a high ACTH levels, as if there was something suppressing the pituitary when the patients were in ICU. Same story for total cortisol and free cortisol. High levels, this is not a surprise, then coming down with time, being no longer increased in the long-stay patients. But when they are discharged to the ward, look at the right panel, then they have high cortisol levels. They're better at that time. So this was very striking and very surprising. Same story for free cortisol, rise when they were improving on the regular ward. Then we did weekly synactin tests. And again, much to our surprise, we found that all these patients have low incremental cortisol responses to synactin, all of them. Is this a failure of the adrenal cortex? And everybody would be in adrenal failure, right? But if you look at the free cortisol incremental response, they're normal, and even some have high levels. So what is this? We were really puzzled about that. And actually, the explanation is already in this figure that I already showed you, where we measured when we said the half-life of cortisol is long and it's not broken down, but we also found in that graph that the peak, we injected 100 milligram of hydrocortisone in patients and controls, but the peak level is much lower in the patients, which means that it's the same amount, that the distribution volume is much larger. And the reason for this distribution volume, of course, is the low CBG. If CBG is low, cortisol is not retained in the plasma, and it's being distributed over a much larger volume. And then, this of course explains that if you do a synactin test, the amount of cortisol that's being released from the adrenal cortex can be perfectly normal, but it's just being distributed in a larger volume. That then doesn't mean anything about the function of the adrenal cortex. This just as an aside, the measures of the breakdown indicate that throughout intensive care, the metabolism of cortisol remains low and never increases. Okay, why is ACTH not increased? There are different interpretations or possibilities. In the concept of Kirki, or failure of the HPA axis, people will say this is because the pituitary or the hypothalamus is damaged. Or we, more critically, said, no, this can be perfectly normal. This could be caused by feedback inhibition at the level of the glucocorticoid receptor centrally. When glucocorticoid levels are high, due to peripheral drivers, this can just be negative feedback inhibition. And the way to differentiate between these different causes is to do a CRH stimulation test, which we did in the next study. When the hypothalamus is damaged, what you expect is an ACTH response that is delayed and increased. When the pituitary is damaged, you expect an immediate suppression of the ACTH release. But when it's feedback inhibition, what you expect is first normal response and then a suppression. So this was the study we did, 3 cohorts of patients, acute, subacute, and chronic phase compared with healthy controls. And this is the data. This is what we expect when it's feedback inhibition, a high normal response initially, and then in the subacute and chronic phase, so beyond the first week, that response is suppressed. So compatible with feedback inhibition by cortisol or any other ligand that can activate the GR in the pituitary. Compatible with, do we have any data, any evidence to say that that is actually happening at the level of the pituitary? We have just published a paper on this. This is a combination of clinical studies and an animal study. And this is the conclusion. I'll show you some data later. But yes, there are data. It is GR ligand binding at the pituitary, which leads to an impaired processing of the prohormone of ACTH, POMC, to ACTH. This then explains why ACTH is low. And as you will see, the prohormone is actually circulating. These are the data from the human studies. The 2 bottom panels show ACTH, low, coming up to normal levels later on in the chronic phase. But POMC levels, which are normally undetectable in healthy subjects, are always high, very high. And this is the summary from the animal data. I don't have time to go into too much detail, but we could show at the different levels that indeed there is an activation centrally, with CRH and AVP being activated. In the pituitary, POMC gene is expressed and translated, but because there is feedback inhibition at the GR, it is not processed. POMC, the prohormone, is not processed to ACTH, resulting in low ACTH but high POMC levels. Okay, academically interesting, but you can say, what does that mean? What is the clinical relevance of this? Are these changes in ACTH and cortisol good or bad? Of course, that is a difficult question and also a difficult hypothesis to test in clinical studies. But we try to get an answer to this, and these are data from a pediatric study that we've done where we had good data to at least do an association analysis adjusted for risk factors. The right part of the slide shows you that the treatment with steroids in these children, adjusted for other risk factors, was negatively related to outcome. Negatively, so harmful. And then in the left part of the slide, you can see this is the population without steroid treatment. In that population, again, adjusted for risk factors, we found that the low ACTH was independently associated with poor outcome and a high cortisol. Knowing that corticosteroid treatments further suppresses ACTH, this fits with that concept. So it doesn't seem to be good to have this suppressed ACTH, at least in the long-stay patients. Why would it not be good to have low ACTH? Well, it is very simple because it is known for ages that ACTH is the most important trophic factor for the adrenal cortex. If the adrenal cortex doesn't see ACTH for a longer period of time, it starts to atrophy. And we have data from, this is post-mortem data from a human study where we found that in long-stay ICU patients, but not short-stay patients, there are signs of adrenal atrophy, such as here, the loss of the cholesterol esters in the adrenal cortex, and also all the genes that are normally driving cortisol synthesis in the adrenal cortex are all suppressed in that chronic phase. So in summary, this is just looking at the data that have been available for a long time in a different manner. What you see is not always what you get. Let's summarize. First, all, at least acute critically ill patients, have high free cortisol availability, which is due to low cortisol binding proteins and suppressed breakdown, not due to an increased production. The clinical relevance hereof, if you would have a patient who does not have an adrenal gland, you don't need to give that patient 300 milligrams of hydrocortisone, because a normal, healthy subject without adrenal diseases would not produce that much, okay? All acute critically ill patients have normal or low plasma ACTH, which is possibly or likely explained by feedback inhibition. This does not mean that there is damage to that organ. All critically ill patients have low incremental cortisol responses to a synactin test. This is because the test is confounded by the increased distribution volume, which is always present, and therefore you cannot use a synactin test to diagnose adrenal failure in ICU patients. It just is flawed. And it explains why Dr. Anani's study showed that there was an association between that suppressed ACTH response, of course, because they're the sickest patients. They have the largest distribution volume. So that is a clinical important consequence. Don't use the synactin test. The elevated circulating POMC levels, we've got new data indicating that that actually may drive the adrenal cortex to at least release some cortisol. And the population at risk for developing real central adrenal insufficiency is the prolonged ICU stay patients, those that suffer from not seeing enough ACTH in the chronic phase of illness. And I think we should focus on that population for further research and for studies. And now just referring to this review paper without going into the data, but it is important to, when you speak about adrenal failure or adrenal function, to take into account the phases of illness, acute, subacute, and chronic. And I refer to these review papers to read more on this. And with that, I thank you for your attention.
Thank you very much for this wonderful overview of long-time research. Questions or comments from the floor?
Too early in the morning.
I'll get the first one. In the study in which you look at recovery beyond ICU, this degradation pathway of cortisol, how long does it take to get back to normal?
We don't have data on this because, to really measure breakdown, it needs fancy studies, and to have that data done is difficult. So we didn't do any tracer studies in the prolonged phase. What we found was that until discharge, it is still suppressed. Why is it suppressed? We think it has to do with bile acids that are increased. It's a long story, but bile acids can actually suppress the metabolic enzymes in liver and kidney. And as long as bile acids, as part of the acute stress response or even chronic stress response in ICU patients, are there, this could actually mediate this suppression. So I think my guess would be that it is still present at recovery. And yet, those patients have this high ACTH and cortisol, which means that either that suppression is gone or there are other factors that suppress the whole axis during ICU stay, which is then gone. We don't know yet what that is, but that's what we think.
Thank you.
Is there any impact of steroid administration on long-term, during the ICU stay, on long-term outcome?
Well, the studies that are available are the studies with treatment with high doses of cortisol, hydrocortisone or other steroids. And there are some data on long-term outcome, but it has not been well investigated. And the problem is that long-term outcome is not just mortality, for example. Long-term outcome of having high levels of steroids could also be cognitive impairment or physical impairment. And I think those studies have not been done. And I think for future studies, we really should look at that. And that's what we are doing in the pediatric study, follow-up study that we're doing, as well as in the adult study. But for intervention studies, this, I think, should be one of the endpoints.
Further questions or comments? Perhaps a quick one. In patients with sepsis, when we measure cytokines, we see that those individuals have upregulated level of pro-inflammatory cytokines for a long period of time. Could you envision any role of the HPA axis to regulate that?
Yeah, definitely. it's a homeostatic response to control inflammation. That is something we know from other inflammatory diseases besides sepsis. So it is an adaptive response. And so I think we should have an activation of the HPA axis to be able to counteract that. The fact that it goes down in the chronic phase then indicates that that may be one of the reasons why there is this lingering circulating cytokine levels or lingering inflammation. And that's why I mean we should focus more on that population rather than septic shock patients, giving them high doses of steroids, which may increase your blood pressure, there's no doubt about that. But that's not, I think, the pathophysiology that we try to understand and do something about.
Thank you very much. We'll move on to the next presentation that will be given by Nicole Ufermans from Amsterdam. And the topic will be risk of herpes reactivation and fungal superinfection.
So thank you for the introduction. I think the next speaker will talk about the efficacy of steroids. And I'm taking a little prelude to that by talking about the risks. But in the end, every intervention is about balancing the risks and the benefits. So this is the assignment. Talk about the two very different but severe superinfections in ICU. And if we speak about the impact of steroids on these severe infections, there are many situations that you can envision, but there aren't much data in all of these situations. So I will dissect it into these circumstances. And let's start with the steroids on the herpes reactivation. I will discuss this in the context of sepsis as well as in COVID ARDS. So just to remind you, at least in my mind, if people talk about herpes, I envision herpes simplex, but actually all of these viruses are herpes viruses, including varicella zoster, Epstein-Barr virus, cytomegalovirus virus. They're all herpes virus. And then you can get infected during your lifetime, and then these virus cells remain dormant and latent in your body, and then they become reactivated. And it's not very uncommon to be infected with herpes virus. In fact, if you measure your seropositivity, so whether or not you have experienced this kind of infection, throughout your life, the majority of people will have been infected with herpes viruses, as you can see here, amounting to an amount of 80% of the population. So thereby, herpes reactivation, this happens in sepsis, and it is also, as you can see here, mild viremia measured in the peripheral blood samples occurs in 80% of patients with any viremia. And if you have severe reactivation, defined as more than 5,000 units per milliliter, this happens most prominently in Epstein-Barr virus and cytomegalovirus, and it's an effective time. So the longer you spend on ICU, the more, the higher the incidence of patients with the reactivation of this virus. So why do these ICU patients have reactivation of their herpes virus? And this sort of relates back a little bit to your question about the effects of steroids, I guess. So these critically ill patients have strongly an inflammatory response, and this strong inflammatory response really has all kinds of effects on the immune system. So for example, the T cells, they don't function well, they don't make interferon gamma. The natural killer cells, they do less well in apoptosis of the microorganism, and also the antigen-presenting part of the immune system by the dendritic cells also doesn't function well. So this is an effect of the strong inflammatory response. And you can imagine that if you are administering steroids, all of these aspects of what is happening here can be affected. So is herpes reactivation relevant in ICU? Well, yes, it is. These are data or a summary which is recently published, pooling all the studies and looking at outcome of the impact of having a herpes reactivation. And they found that really the load of CMV is associated with death. So the higher the load, the more risk of dying. But also having any reactivation was already associated with an increased risk of dying. So yes, herpes reactivation seems to be relevant. And this study looked at risk factors, and they found that the disease severity is a risk factor for the reactivation. But corticosteroids weren't investigated in this pooled analysis. So the data here are really very scarce. Actually, one of the single studies that I found is this study done by researchers in Utrecht in the Netherlands, looking at risk factors for herpes reactivation in peripheral blood samples in patients with severe sepsis. And what they found again is that the disease severity is a clear risk factor, but they also showed that a high dose of corticosteroid use was associated with more patients having a viremia. And this was an independent association trying to correct for this disease severity. So what about COVID ARDS? Some limited data are here. These are a series of patients admitted to the Hemato-Onco unit of the intensive care, in which an increase of viral replication was shown. Also, again, as a function in time, and we know, of course, that COVID patients stay on our ICU for weeks. And in this limited study, also, they found that dexamethasone was a risk factor for herpes reactivation in COVID. That's the same question that we asked in our center, which was a single center study with all of its limitations. But the good thing is that we applied, as part of standard care, a non-directed bronchoalveolar lavage. So in every patient admitted to ICU in need of mechanical ventilation, we did this ball fluid and measured the reactivation. And what we found is that reactivation occurred in the lungs in 36% of the COVID patients. And then looking at comparing patients with this herpes reactivations to those without a herpes reactivation, you can see that the population, well, they were predominantly male, they have overweight and hypertension, and they are around 70 years of age, no difference there. And also, the amount of patients receiving dexamethasone was the same, and actually the recovery trial was in the middle, came out in the middle of our data acquisition. So part of the patients prior to coming out of the recovery trial didn't receive dexamethasone, whereas following the recovery trial, everybody received dexamethasone. So this really gave us the opportunity to look at the effect of dexamethasone. And if you look at high doses, defined as over 30 milligrams or over 100 milligrams, the amount of patients with the herpes reactivation was higher in those receiving high doses of dexamethasone. And also the patients with herpes reactivation, again, they were sicker. Longer time on the ICU, longer time on the ventilator, and higher SOFA scores. So this is a repetitive finding. And if you think, well, it may not be that clinically relevant, this CMV reactivation in COVID, I don't think the data are very robust and there yet, but I would like to highlight a case report in which in a previously immunocompetent patient, although treated with dexamethasone and anti-IL-1 receptor antagonist, invasive disease was found in the colon of this patient. So it can cause invasive disease. So to summarize on herpes, it's related to disease severity and it's associated with adverse outcome. There are just a limited series of observational studies. They suggest an association with steroids, but the risk of confounding is huge, I think. So my personal opinion would be that if there is an indication for steroids, the reactivation of herpes should not be a reason to withhold those. So then move over to invasive pulmonary aspergillosis. I'll speak to this in the context of influenza ARDS as well as in COVID ARDS, because there are some data on that. So why is there a viral infection a risk factor for invasive pulmonary aspergillosis, apart from all the effects of the immune system that are going on? There is also the presence of severe ulcera caused by these viruses in the trachea and the bronchi, as you can see here. And you can imagine that this kind of ulcera causes a breakdown of the natural barriers by which the fungus can enter the pulmonary system and cause invasive disease. So this is an already 10-year-old observational study, one of the first one during the pandemic of H1N1, reporting a very high level of EPA in these patients, 23%, and there the observation was that 80% of these patients were using steroids. So we recently did a very large case control studies in a lot of hospitals in Belgium and in the Netherlands, pooling all the data about influenza pneumonia, comparing these with patients with bacterial community-acquired pneumonia, and then looking at risk factors with the multivariate analysis. And what we showed is that the presence of invasive pulmonary aspergillosis wasn't independently associated with adverse outcome. And what we also showed that, being male was a risk factor. But also, again, the use of steroids was a risk factor for mortality in this patient cohort. And all of these studies have been summarized recently in a Cochrane meta-analysis, and I think the data are quite clear in the fact that the use of steroids during influenza pneumonia is associated with adverse outcome. It's not favorable. So what about COVID? Also there, the same incidence of invasive pulmonary aspergillosis have been found. So there are numerous observational studies. I'm showing one of my own, but the incidents are similar to that found in influenza, around 20-25% of invasive pulmonary aspergillosis. And again, we diagnose this as an increase in the galactomannan in the bronchoalveolar lavage fluid, plus all of the clinical risk factors. So what are the data on the risk of steroids here? Well, this is also, again, a very limited number of patients. We found that the disease severity score is a risk factor for EPA in COVID and having COPD, but the use of steroids, I guess the numbers are not robust enough to say anything about that. What we do, again, this is a case study highlighting that Aspergillus can cause fatal invasive pulmonary aspergillosis in COVID. But my reasoning here is that this is probably a rare finding because we have had so many COVID patients in our ICUs and we do have histology studies with them, and there have been no reports coming out, beware of Aspergillus. So in my mind, this is a rare finding. So if we take all this together, steroids are a clear risk factor for EPA in influenza. It's associated with disease severity. I don't think it should be avoided. EPA occurs equally frequent in COVID, but I guess the benefit of steroids clearly outweigh the risk because it's associated with a reduction in mortality, so it shouldn't be withheld. But my personal opinion is that I guess if you have this COVID patient and you find the Aspergillus in the lung, I would personally be careful with giving higher doses of steroids than the 6 milligrams dexamethasone. And with that, I would like to end. Thank you for your attention.
Thank you for this excellent talk. Is there any question from the audience? I have a short question, the classical question. Do you introduce a treatment in a patient with high-dose steroids for any reasons?
You mean treatment for the super infections?
Yeah.
Well, if there is ARDS, so if we find this in patients that are recovering and they don't comply to the definition of ARDS anymore, we don't give any medication for the herpes reactivation. But if patients still have severe ARDS, we do give treatment for the herpes reactivation. And the pulmonary invasive aspergillosis, the same thing.
So one observation that we made, and many others did so, that when you have a reactivation or with CMV down the road in a number of patients, you have fungal reactivation as well due to the immunosuppressive effect related to CMV. Is that something that you have seen as well? You first reactivate the herpes viruses, including CMV, and if you get reactivation of CMV, I would be extremely careful down the road for, again, a superinfection with fungi. So, dexamethasone is a risk, then CMV activation is a further risk, so it increases the risk of fungal infection. Did that happen in your unit?
Yes, we also have co-infections. I don't know about your personal experience, but again, this seems to be a function in time. So the patients with prolonged, a protracted course of COVID, and they can have also first the herpes reactivation, and when that is treated, they have the fungal superinfection. So our clinical practice is to repeat this bronchoalveolar lavage at least every week in every patient that is not responding well or who has a protective course of disease. Yeah.
Another comment. We are looking very hard to find fungal infection, particularly Aspergillus, in COVID patients, including those who are now on steroids. And we do not have the same picture as you see in the Netherlands or in Belgium with about 20%. We are down to 3-4%. And it hasn't increased after the use of dexamethasone. So my question to you is that why is that it's so high in the Netherlands and Belgium? In Paris, it's not that high. I asked my colleague, it's also low. So is there anything special going on in Benelux?
Yeah, that sounds a bit fishy. You know, of course, that the Aspergillus that you inhale in the lungs really depends on what is going on within your vicinity. I guess people didn't travel a lot. Maybe there's a lot of Aspergillus in the compounds in Amsterdam. For that, I don't really have an explanation. We know also, but in other studies, that is not about one single species of Aspergillus. You can have inhaled multiple species of Aspergillus. So I guess there are some differences around the globe in the burden of Aspergillus within the environment. That would be one explanation that I can think of.
And the final question, if you have an incidence of 20%, do you prophylax them with azoles?
So in Belgium, there have been some studies and also about the nebulization of amphotericin B, which in my mind is quite an elegant solution to this. And for the others, you know that we give selective digestive tract decontamination. So we use the topical application of amphotericin B within the oropharynx and as a drink that you ingest. So yes, there is a general policy of instituting antifungal preventive measures in the Netherlands.
And is there any data comparing center using SDD and those not using SDD on reactivation?
Everybody receives SDD. There is no control.
In Netherlands, yes, but elsewhere it's not the case. There is no control study.
I'm not aware of that comparison yet. Yeah, it's a good question.
So thank you again for this night talk. And we move on to the next speaker, Jesús Villar from Madrid, Spain. And the talk is about dexamethasone for all ARDS after COVID.
Thank you. I would like to thank Jean-Louis Vincent and Fabio Taccone for the invitation to be part of this meeting. And I would like to thank you, all of you, because you have been here very early in the morning and compared to other sessions. So I would like to start by, let me see if I have to see here. Yes, my conflict of interest is not related to the talk I'm going to give you today. This is a beautiful picture from an editorial by Peter Suter that was published at the New England Journal of Medicine in 2006, because was invited to give a talk, to write the editorial about the study in the United States on steroids in ARDS. The first author was Steinberg. Okay, and this figure is useful, and the editorial that I recommend you to read it still today, because you learn that corticosteroid has very strong anti-inflammatory effects because it's, affects many pathways. And in fact, the corticosteroids can switch off genes that are activated due to inflammation and switch on genes that encode anti-inflammatory proteins. So the ARDS is not really the only syndrome under the umbrella of the cytokine storm syndromes. This is a figure that is known by oncologists, hematologists, rheumatologists, to many specialists in many disciplines, because they have been witnesses of this cytokine storm. That is a name for the excessive cytokine release during out of control immune activation. But historically, all those syndromes were treated with corticosteroids to reduce disease severity. So ARDS is not something different from those cytokine storms. However, according to the experts, I know that Grit and Nicole are more expert more than myself. I'm not an expert in corticosteroids. They tell you that there are several determinants of the clinical efficacy in the specific field of ARDS of using corticosteroids. One had to be related to the timing of initiation. I think most of the trial that has been negative is because they start corticosteroid very late. The dosage, according to the new information, so I think we had to give a dosage close to maximal saturation of the glucocorticoid receptor. In the case of methylprednisolone, it's about 8 to 100 milligrams. In the case of dexamethasone, was 20 milligrams. Dose of administration could be given by a bolus or by continuous infusion. Duration, is no concern about to use high doses for a prolonged time, according to Meduri. And then we have to be careful about dose tapering to avoid a rebound. But anyway, those concerns, are still under study. So during the epidemic in February, Meduri and I, we contact each other to try to convince the World Health Organization to change the document about the non-use of corticosteroids during COVID. So what happened is we review and revise all the clinical trials on ARDS. Of course, this is non-COVID ARDS, who were including patients randomized before day 14. And we found like 10 randomized control trials with more than 1,000 patients from 8 countries. And it turns out that the, let me see here. I don't see, well, at the end, the net effect of this, of the administration in these trials was positive. I mean, the save life, prevent death. So with this idea, we try to convince the people to use corticosteroids because people were dying, and in many ICUs and in many countries, the death rate was very high. In this meta-analysis, you will see here, is one of the studies that was coordinated by me. That was the last one, and is the largest one. So using different methodology was published in Intensive Care 2020. Arul Kumaran did, a review of all the studies of using corticosteroids in ARDS, including even the recovery trial they use in COVID. And you will see that there is very difficult to compare all these studies because the definition of ARDS is different, the time of initiation is different, the dose, the corticosteroid that they use is different. Everything was different. So it's very difficult to compare orange and apple grapes when you have different studies done in different time using different kind of patients. But anyway, the idea of this lecture was to present to you, and then some opinion afterwards, about our study was the DEXA ARDS, that I think was an inspiration for the recovery trial. So this is, as you know, was published in the Lancet before the pandemic. It was accepted before the pandemic. I was published the first week of February in the Lancet Respiratory Medicine. So we did a randomized controlled trial with patients with established ARDS. This is non-COVID ARDS. And so the idea was that our hypothesis was that the corticosteroid, in that sense, was the first time we used dexamethasone in ARDS. It is the first time that dexamethasone was used to treat ARDS patients in the world, was able to reduce, to save life. But the first primary outcome was to reduce inflammation, to reduce the need for mechanical ventilation, to decrease ventilatory-free days. So we include 277 patients. They were randomized to receive dexamethasone during 10 days. I know we have some question at the end. This is arbitrary, regime. We decide by consensus to give for 10 days. We select the doses by consensus. We give 20 milligrams during the first 5 days, followed by 10 milligrams, half of the doses in the following 5 days. And then the control group didn't receive dexamethasone. So the primary outcome was ventilator-free days. And we know already, it was a surprise for us, that the ventilator-free days was much higher in patients treated with dexamethasone, but the mortality rate was reduced by an absolute 15%. That is a lot. I don't know of any other treatment that reduces mortality for so much. So 15% mortality rate reduction, absolute, okay? So this is the graph, and you see the survival. That is from the very beginning, the two groups start to separate it, and this is a survival curve at 60 days. During this time, during the review process, and then the publication online on February the 7th, we received many phone calls, and even from Oxford, talking about if we can do an analysis, a subgroup analysis on these patients to see which one is going to benefit the most. But you see, in randomized controlled trial, it's not recommended to do subgroup analysis because it's unreliable. Second, you have the play of chance. And third, you don't have a statistical power to see which group will be the best. But anyway, you can see here the most frequent causes of ARDS was pneumonia and sepsis. And in those groups, the effect was the dexamethasone reduced always mortality in all this group. In trauma, we don't have so death in the dexamethasone group, but the small number of patients prevent us to do some sub-analysis. However, what about pneumonia? Nicole talked about the viral pneumonia, and I think here was a surprise for us because this was not published, because as I said, it's unreliable to do a subgroup analysis, but we found that 62 patients has H1N1 ARDS, it's a viral ARDS, and the dexamethasone, the signal of dexamethasone was more positive, stronger in H1N1 in the viral ARDS than in the bacterial ARDS. So contrary to the knowledge that we had in the past with the other viruses, okay? So, but anyway, because the sample size, we didn't reach significance, but you can see there that is the signal is very strong. So H1N1, even though it was a concern for physicians participating in this trial, at the end they found out that the mortality rate was even lower. So the recovery trial, I think we feel very fortunate to have, to be that our study was an inspiration for the recovery, for Oxford, for the Imperial College. And they designed a randomized controlled trial very fast during the epidemic. In 15 days, they have everything done and the approval. And they collect data from 176 centers in the United Kingdom, from Scotland, England, North Ireland, and Wales. And we don't have data, of course, we don't have data on ARDS in this study. And I'm waiting for that because they have a tremendous amount of data. But they did a very simple and very brief randomized controlled trial, asking very few questions. And I want you just to pay attention to those patients who were mechanically ventilated. We don't have the exact number of, not only the exact, we don't have any information on how many ARDS were in that group. But patients mechanically ventilated, some of them should have ARDS. The number of deaths was much lower. It was about 13% lower. So very close to what we found, about 15% absolute decrease. So this is not a slide to read, but after the recovery was published, or press release, all the studies in the world testing the effect of corticosteroids in COVID patients were stopped. And we, so under the coordination of the World Health Organization, even though those studies were stopped, so we decided to do a prospective meta-analysis of all of them in many countries, and in fact, in 12 countries, we were able to get information from almost 2,000 patients, including those mechanically ventilated in the recovery trial. And we can say that at the end of this prospective meta-analysis, that only studied 28-day mortality is the same thing as the recovery trial reported. The corticosteroids, whatever you use, methylprednisolone, hydrocortisone, or dexamethasone, was reduce, prevent death in critically ill patients with COVID. I don't say ARDS, but the word used for most investigators was critically ill patients with COVID. Most of them, of course, were ventilated. Now, because that study was coordinated, that analysis was coordinated by the World Health Organization, they try to set up a new guideline, recommending the use of corticosteroids, and they published those recommendations the same day as the JAMA published our study. It was on October the 2nd, I think, or September the 2nd, on 2020. The first recommendation, as you know, is that the systemic corticosteroids should be given to patients with what they call critical COVID, that means patients who require oxygen, mechanical ventilation. Now, however, despite that now it's a standard of care to give dexamethasone, or at least to give equivalent doses of other corticosteroids, so there are many questions still remain without an answer. One is related to the use of the 3 corticosteroids. Which one we should use? Well, I will say that I have no an exact answer for that, but at least dexamethasone, because it's the largest randomized controlled trial, was the recovery, and then our study in ARDS was the first one, and the only one so far. So I think dexamethasone merit priority. I don't say that we cannot use the others. In fact, very recently, I think last week, the Danish finished the steroids 2 trial, and they use hydrocortisone, I think. So now we are expecting for the results, but very soon will be reported. And now, when to use dexamethasone? I will say at ARDS onset, if patient is intubated. This is the information that I have from now that is reported. Maybe in 2 months we have a different answer for this. We use, patients in our study there, the DEXA ARDS, they had established ARDS, they were given steroids 24 hours after being diagnosed, so very early. We don't wait 7 days or 14 days like in the previous studies. And I think at the onset will be fine if you don't need to wait 24 hours. Now, how much dose? Well, according to the expert, it seems that we have to be close to the saturation of the corticosteroid receptor that I said before for the DEXA is 20 milligrams. This is the dosage we use in our study. And then reduced to to the half at the following 5 days. And then for how long? Well, as I said, it was by consensus, but was arbitrary to choose 10 days. The same days we did in the study for 4 years, the recovery used the same period, 10 days. So now we had to see, some study had to be in the future, whatever 8 days or 12 days or 14 days, we have the same results. So now the conclusion for me is that we have, at the moment, we have strong evidence that corticosteroids can reduce the risk of death in patients with ARDS. We have a strong evidence that corticosteroids can reduce the risk of death in patients with non-ARDS acute hypoxemic respiratory failure, because this is based on the data we have published. We don't have strong evidence that for when to initiate and for how long to use corticosteroids in ARDS at the moment, and whether dexamethasone is the corticoid of choice in ARDS, merits further studies. Thank you very much.
Thank you very much, Dr. Villar, for this nice overview of a debatable issue about steroids, when, how, for how long, which dose. This is open for question or comments. Feel free. Yes, please. Can you come down to the microphone? Thank you.
Congratulations, Dr. Villar, once more. Well, I have a question. What do you think about the reactivation of ARDS in the process of the disease? Because sometimes we use steroids more than one time. What do you think about that?
Well, let me see. In our trial that with as non-COVID ARDS, and now everybody who are in the ICU and participated in that study, they are using dexamethasone because they have the expertise now and the experience. It doesn't matter at what time the ARDS is diagnosed during the evolution of the acute hypoxemic respiratory failure. They give, we don't have data on that, but they give the dexamethasone at the moment of the ARDS is diagnosed. It doesn't matter if the patient has been 2 days or 10 days on mechanical ventilation.
Yeah, but do you think there can be a second reactivation?
You can have, yes, you can improve your ARDS, and eventually you have an extubation failure. You need to be reintubated, and the patient, because has a secondary pneumonia or they have another sepsis process, you develop again ARDS. Well, I don't have data, and nobody have data at the moment of what is the results of giving steroids at that time. Not only that, I don't know of anybody who can recommend to give steroids when already the patient was extubated in the previous treatment. No data. So if no data, I cannot even recommend anything that is not reported by any data. But of course, it could be, patient could develop ARDS after being successfully extubated from other complications.
Not when the patient is maintained in mechanical ventilation.
Yeah.
Not after extubation. Even
Or even
a long process in the ICU.
Yeah, but so far the trial was 10 days, and I think in the recovery trial was the same thing. And clinicians stopped it at 10 days. They didn't give it for a longer period of time.
Thank you.
A quick last question. You told that the best dose is corticosteroid receptor saturation. It's not clear for me.
Well, let me see.
What is the best dose for you? 6, 12, 20?
Right. Let me see. There are so far at the moment, there's few studies. One in Italy, I know. One in Denmark with Indian centers. One in Spain. They are testing the effects of the recovery dose versus the DEXA ARDS dose. I mean, 6 versus 20 and then 10. We don't have the data yet. That would be very nice because we don't have the data to recommend. As I said, we did it by convention, by consensus, but we don't have data that 20 is better than 6. For me, it was a surprise, of course, that 6 milligram a single dose for 1 day, every day for 10 days was enough, was able to decrease mortality in ventilated patients with COVID by 12%. That was a big surprise for me.
So final comments or questions, and then we wrap up because we have to go.
I would just want to make a comment on the receptor question, because there is not one receptor to start with. So the glucocorticoid receptor is regulated in the presence of high levels of steroids. They can be downregulated in one tissue, upregulated in another. So I think it's a bit simplistic, in all honesty, to say saturation of the receptor. That doesn't exist. And actually, if you speak about doses that can saturate a glucocorticoid receptor, whatever is present in an ICU patient endogenously does this. So we're talking about pharmacological anti-inflammatory treatment with dexamethasone. It is not about just glucocorticoids.
Yeah, thank you.
Activation.
Thank you for the comment.
Well, thank you very much for that. So I would like to thank the 3 speakers for a wonderful presentation. You to attend early on, and it has been a pleasure to co-chair with Dr. Leone from Marseille. So thanks a lot. Enjoy the rest of the morning.